The following podcast is part of a certified educational activity titled Hitting the BCMA Target in Multiple Myeloma: Insights on CAR T Therapy and Innovative Antibody Options. Access the entire activity and complete the post-test at peerview.com/FNM860. Downloadable slides and practice aids are also available.
Okay, so today you're going to have two panelists. That's myself, Tom Martin from the University of California, San Francisco, and my friend and colleague, Dr. Karina Patel from MD Anderson in Houston. All right, so I'll start with just a few baseline slides, and that is, so BCMA has now opened up a fourth pillar of therapy in multiple myeloma. So we've had three pillars of therapy on my mind: proteasome inhibitors, immunomodulatory drugs, and CD38 antibodies. And those have actually certainly expanded our survival in patients with multiple myeloma, and certainly the combinations have allowed us to have numerous therapies for patients with relapsed and refractory disease. But BCMA is now going to bring us to a new forefront with the fourth pillar. We do have another pillar, obviously, alkylators that we use a lot here in the audience. We use a lot of alkylator-based therapy, especially with transplant, and we also use a lot of steroids. But with all of those, we now have quite a few options, and the real, I think, important thing for us is to know that in the next 5 to 10 years, what we really want to find out is what is the best sequence of all of those therapies. So BCMA is really a great target. It's lineage specific. It begins its expression at the germinal B cell, and it's expressed on the mature plasma cell and with higher expression on nearly all malignant plasma cells. Signaling is also implicated in disease progression and drug resistance, and perhaps by blocking BCMA there may be some therapeuticity of doing that. Now, the BCMA as a target now has led to multiple improvements in relapsed refractory myeloma. We've had 4 agents approved in this space. Belantamab mafodotin, unfortunately a checkered past. We'll talk briefly about that. 2 CAR T cells, captogene Viclucil and siltacaptogene autoleucel, and also a bispecific, our first bispecific approved, teclistamab, about 4 months ago, and I think we're all just getting our hands wet on using this as a standard of care option. So now in this space, all of these drugs with BCMA-targeted therapy they're being used and tested in the far right, I say the far right of myeloma therapy, when patients have relapsed refractory disease, when they're so-called triple-class refractory or penta-drug refractory. These are patients that really have very limited options, correct? And so if we look at the mammoth data on the graph on the left, you see that those patients that have triple-class refractory disease or penta-drug refractory disease really have poor survival. It's really generally less than 12 months. This was corroborated on the right in a presentation at ASH this year from a Canadian group looking at patients who are CD38 refractory, and in fact, again, the overall survival being less than a year, and really upwards of more than a third of patients that do not go on to a next line of therapy in that scenario. So what are we going to do today? We have a few goals. We're going to try to provide all the evidence that we have up to date. Now, it would take us 10 hours to provide all the evidence. We're going to do snippets of the evidence of what we think are important for you to know, both in the CAR T-cell world and also bispecific world. We're going to share some guidance in terms of how to implement these therapeutics. I always tell myeloma is a disease of treatment that's based on art, sometimes more than it is data. And so, everybody can be their own artist. You're going to use these data that you learned today to hopefully develop your easel and paint your picture at home at your own institution. We also want to equip you with the skills to manage safety concerns that are associated with these BCMA-targeted therapeutics. The most important part, there are safety concerns that we have not seen in other therapeutics that you really need to know when we do therapy with BCMA-targeted, whether it's CARs or bispecifics. And with that as an introduction, I'm going to bring up Dr. Patel. She's going to talk about aiming for remission with BCMA CAR T-cell therapy. Karina, it's all you.
Perfect. Thank you. Okay, so I'm going to go through all of CAR T in about 18 minutes, but the first half is data that most people here probably know, so I'll go through it sort of as an introduction, and then focus a little bit more on the newer studies that have come out, and some being presented here at Tandem. So in the NCCN guidelines, we do have 4 different BCMA therapies that are approved right now, greater than 4 prior lines of therapy. And the 2 that are CAR-T are idacaptogene viclucil and ciltacabtagene autoleucel. So ide-cel was the first BCMA CAR-T construct that was approved. It's an anti-BCMA CFB, and then 4-1BB. And the overall response rates for these patients has been, compared to anything we had before this, pretty phenomenal. So again, overall response rates of 73% and about 85% for those who had 450 million cells. So this is the original KarMMa trial, the pivotal trial for approval, and these were triple-class refractory patients. So obviously the introduction that Tom just gave on patients with triple-class refractory disease are usually pretty dismal otherwise. So again, overall response rate of 73%. The median time to response, 1 month, which is pretty new for us as well. And then for this trial, the big thing was that dose did matter. So the higher dose you got, the better response. So about 450 million cells is what we aim for when our patients are getting standard of care. And again, the deeper response, so those patients that got a CR or stringent CR, which is about 39% for the patients who had 450 million cells, usually means that they're going to do better by PFS. So again, overall, according to the target dose on the left, basically the blue line is the 450 million cells, and those patients' median PFS was 12.1 months. And then if you look at prior lines of therapy, they didn't really see a big difference between 3 lines versus greater than 4. But again, the patient populations were a little bit different. But the median PFS was 20 months in patients who had that CR, stringent CR. Our biomarkers that are helping us decide what to do with these patients, because CAR-T has not been a cure yet for our myeloma patients, unfortunately. It's really improved survival, PFS, quality of life. However, we need biomarkers to know who's going to do really well and who do we need to watch out for. And I think the next generation flow versus next generation sequencing, if you have MRD that is negative at 12 months, sustained MRD undetectability, patients do much, much better than if they are not sustained or if they don't reach MRD negativity. And then so coming to the real world data. So this was one of the first studies that's been published. This was part of a US consortium for cell therapy, and included 11 different centers around the US, and it had about 150 something patients that actually got infused. So 77% of these patients wouldn't have met KarMMa criteria, mostly from cytopenias, renal failure, renal insufficiency, cardiomyopathy, lots of different reasons, prior BCMA therapy, which the trials originally didn't allow for. And as you can see, in terms of PFS, we've actually seen similar PFS rates for all patients was about 8.8 months, and survival has been actually very similar as well. So most of these patients have done really well. Looking at creatinine clearance, there was another study done by Dr. Sedana, a poster at ASH, that we have to adjust fludarabine, just like with everything else, but we've actually seen responses that were very similar to the KarMMa data. And again, PFS was 0 to 2, and we had a couple of patients that were PFS 3, so different than the trial. So then coming to the next, cilta-cel was the next CAR-T that got approved. Again, the difference here is there's 2 binding domains with 2 different epitopes of scFv. Again, 4-1BB is still the co-stim domain. And CARTITUDE-1 was, again, the relapse refractory patient population greater than or equal to 3 lines of therapy in triple class exposed. Whoops. So we all know the 98% response rate, never seen anything like this in, even in upfront trials for the most part, 82.5% stringent CR, which the depth of response was pretty phenomenal. And of course, it's being looked at in earlier lines of therapy now too. And so actually I think Dr. Martin was also one of the people that presented some of this, but Dr. Usmani presented this at ASCO 2022. But CARTITUDE-1, there was a follow-up at 2 years after the last patient was infused, and really just shows these phenomenal responses. There could be tails, especially for patients who are MRD negative greater than 12 months. So we're hoping that maybe those are the patients that we can eventually call cured. Again, we don't have enough data to say that yet, but our goal is to bring everybody up there. And then again, MRD negativity. If you got MRD negativity that was sustained, despite having high-risk cytogenetics, ISS status, or treatment history, you did really well. So that's sort of where a lot of our clinical judgment that we use to say if someone's going to do well or not might not answer the question for us, but the MRD piece has been really, really instrumental. I will add that for people with extramedullary disease, making sure we're looking at their PET scans is still important too, since the bone marrow won't tell us everything. So then the question about sequencing. So this is really important because we can't cure myeloma, because there's access issues, what do we do when a patient's in front of us and I can't get them, let's say, a CAR T cell or a bispecific or vice versa, whatever's happening. Is it okay for us to give a BCMA and hopefully in the future treat them with a different treatment? So if you had prior cellular therapy, if you had prior BCMA treatment before the cilta-cel on trial, Adam Cohen presented this data recently that the response rates, you see are lower. So instead of the 98% we saw, it's in the 60s, 60%, 57% for bispecifics versus 61% for ADCs. That's still double what we see for selinexor or daratumumab. So even though it's lower, this is still probably as a single agent higher than anything else we have in the BCMA refractory patients now. The one thing that I think we need more long-term follow-up, but the PFS is a little bit shorter. Again, probably better than anything else we have available, but 5.3 months for a prior bispecific, 9.5 PFS for prior ADC. So shorter than if you didn't have a prior BCMA therapy. And then one of our fellows at MD Anderson, Dr. Ferrari, actually presented this at ASH on our real-world data set for ide-cel. So not looking at trial patients now, in the real world, what is happening? A lot of these patients did have prior BCMA therapy. So the response rates were actually still pretty good. Now, if you had prior ADC, 68%, so lower than that 85% or so. If you had a prior bispecific, 86%. These patients, most of them had not had the full dose of bispecifics, though, just to put that in context. These were patients who were on clinical trials, some of them on phase 1 dose escalation studies. And then if you got a CAR T, it was 100% response rate. Small numbers, of course, but I think enough data to say we need to look at this further. And when you look at the PFS, it was the same thing, that the response rates looked good, but the PFS for prior ADC and prior bispecifics was still pretty short, 3.93 months, 2.83 months. These patients have had more lines of therapy, so it could be the disease as well, but again, just something we need to kind of learn more about. So the general principles for effective delivery of CAR T therapy, again, the dosing is a little bit different for the two, and I think it's because the constructs are different and their expansion is different. When we think about CRS, with ide-cel, we see it day 1, day 2. With cilta-cel, we usually see it a little bit later, day 5 to 12. So there's some things that we do differently, but really the referral to the healthcare facility should happen pretty quickly. So if we're getting more and more slots now, which is great, but I need to see those patients at least one line before they're actually eligible for the CAR T. We don't use, filters. That's a big difference. We do avoid prophylactic use of dexamethasone, which is different than other, for stem cell transplant, for instance, et cetera. But we try to avoid dexamethasone. So for my patients, even during bridging, because we use a lot of dex for myeloma treatment, we try to stop it at least 1 to 2 weeks before the apheresis if we can. And I look at their ALC counts and try to change therapy if I need to make sure their ALC count goes up. And the AE events to monitor for all of these therapies. I will say that I think CRS and ICANS, but they're there, but I would say that compared to lymphoma CAR T, they're probably one step down, and then Tom will talk about bispecifics, where it's probably one step down from the myeloma CAR T. And again, the LD chemo, the biggest difference we've seen is we have had shortages of fludarabine on and off, so hopefully there'll be data soon that will tell us if that happens again, what to use instead. And renal function is the biggest thing with myeloma patients in the real world, to make sure you're looking at that. And so here's the CRS and ICANS. So again, high rates of 95%, 84%, but this is grade 1, 2. So for us, this is much easier than lymphoma. And most of these patients are treated with acetaminophen or tocilizumab, and it resolves. A few patients with grade 2, and really not very many with grade 3 or 4. Again, median onset, very different for the two products. So 7 days for cilta-cel and 1 for ide-cel. So most of my patients for ide-cel are admitted, just so we can, monitor that and treat it quickly and then get them out of the hospital versus cilta-cel. We've actually been trying to do it outpatient for this reason and admit when their CRS is starting to occur. ICANS we don't really see very much of, which is good. Infections are the big thing that I think Tom is going to talk about with bispecifics as well. When these patients are really relapse refractory, they're already at a high risk of infections, and with CAR-T, I'll say it's in the first 3 to 6 months that we see this. There are some other, prolonged cytopenias, et cetera, that again in relapse refractory patients we see. There are a few patients we've actually given stem cells to that we had saved from their prior auto. But for most patients, this resolves in the first month, and again, most patients by 3 to 6 months, they don't have any problems. Okay, so I'll spend the next 7 minutes, 8 minutes on earlier use of CAR-T therapy, and what does that mean? Do we think it's better? So I got to present KarMMa-2A at ASH, and this was a group of patients that we consider high risk. They had transplants. There was about 37 patients that had transplant in upfront therapy with their induction, but then relapsed within 18 months of their initial therapy start date from their diagnosis, basically. And so we know that those patients biologically don't do very well. So then they all received ide-cel as their next line of therapy. So they had not had a CD38 antibody. So 31 patients total. Overall response was 83.8%. The CR rates were 45.9%. And again, the depth of response matters. So the 46% is probably what's driving the PFS. And again, the early deep clearance of tumor was seen in the patients who had that greater CR and those who actually had the sustained CR at 2 years. And there was less CRS and neurotoxicity than we saw with patients who had later lines. So again, maybe their disease was a little bit better controlled going into this, or was it because their T cells are different? We don't know, but we actually saw a little bit less severe toxicity. And then the presentation that I think Dr. Geralt is going to give here at Tandem on KarMMa-3, which is the first phase 3 randomized study of ide-cel versus standard of care. And again, the ide-cel was 150 to 450 million cells dosing. And for the standard of care, these were the available therapies for both US and ex-US at the time. So DPD, DVD, IRD, KD, or EPD. And choice was up to us, but also depending on what the patient just had previously to try to make sure they get something that hopefully would actually work and that they're not refractory to. And those patients have had CD38 before. So again, a different patient population than KarMMa-2. So, the New England Journal paper came out last week, and again, looking at the PFS for ide-cel, the response rate was 71% versus the standard regimens 42%, and looking at PFS, median 13.3 months versus 4.4 months. So, I think that this is low, 4.4 months in general, but this just tells us that the more refractory patients are, even earlier, we're going to need better therapies. So I think we can go into that discussion a little bit later, too. And then CARTITUDE-2, also in high-risk patients in earlier lines, looking at patients who had, so this group was actually patients who had transplant or didn't have transplant. So it's a different patient population, but still relapsed earlier than we would have expected within 12 months. Again, high response rate, 100%, 19 patients. And then 90% remained progression-free at 1 year. And then just to mention that CARTITUDE-4 is the other randomized CAR-T trial of cilta-cel versus PVD or DPD, that there was a press release that did show that there is a positive response, and hopefully we'll see more of that data in the near future. So really the take-homes here are, patients with relapsed refractory myeloma progressing after 4 to 5 prior lines of therapy are good candidates for CAR-T. Our real-world data does show that patients that would have been considered too old or frail, our oldest patients are 84, that have gone through, and 100% response rate for our older patients because their performance status is really good, and we do look for comorbidities. Biggest thing, avoid alkylators, especially bendamustine, that just kills the lymphocytes, but even high-dose Cytoxan or the weekly Cytoxan if they're on for a long time, and high-dose steroids. And then again, start the process 1 line prior. Bridging can be an issue, so we talked very closely to our colleagues to make sure we have bridging done. Sometimes it takes 2 cycles of bridging before we get the cells back, so we want to make sure that bridging it keeps our myeloma controlled, but doesn't cause major toxicity. And then high-risk patients, I think, are logical candidates for earlier lines of treatment because it hopefully will change their outcomes. But this population hopefully will go to standard risk as well, because we know that patients who have standard risk usually do better than what our high-risk patients do. And then the big thing with CAR talks, so when at 3 o'clock in the morning I'm getting paged for all the different lymphoma and myeloma CAR T patients that are getting CRS or ICANS, having a tool like this has been great to just plug in what's happening. The nurse tells me this is the fever, this is what it is for oxygen, et cetera. And then I can come up with what I need to do. And it's taught all of us to figure it out faster, but there's lots of different tools. This is just the one we have at MD Anderson.
So before we move on, before we ask the questions again, because we have some time, I'm going to ask Karina some questions. And so Karina, you just showed a blurb about CRS with the CAR-Tox tool, et cetera. I'm just curious, what is your platform for treating CRS? What do you do if somebody has grade 1 CRS or grade 2 CRS? How do you treat that at MD Anderson?
Yeah, no, that's great. This is where the art comes in. So I know most other centers will probably treat grade 1 much faster than us. We usually start with acetaminophen and supportive care. Now, if the fever curve just keeps going up, and if that patient had a lot of disease burden going in, or they're frail or something that I'm worried about, I use TOSI much faster. Now, if they were fit and otherwise doing really, really well, I might wait till that 3 days of fever before doing it just to make them feel better, or until they're really grade 2 CRS. So I think, again, we know that TOSI probably doesn't affect the outcomes, but again, the cost, and does it increase risk of infection for some of our patients? So we're still trying to figure out that right population. But I know you guys do it a little differently.
That is great, and that's where, again, this is where the art of myeloma changes and where you guys have to develop your own platform and plan. So at UCSF, CRS always happens at 2 in the morning. I tell everybody, it's 2 in the morning for CRS. So when that happens, there is no data that given to tocilizumab decreases their response rate. So we actually do tocilizumab with first fever. We just want to turn it off right then and there. CRS does have a duration of 2 to 4 days, and so we do first fever, tocilizumab, and then if the fever persists, we do a little steroids. We throw on some dexamethasone, and then other agents if you continue to have that immune activating signal. All right, so I have another question for you because we have some time, and that is, so the data with CARs is amazing, right? The very high response rates, very high PFS. So is there any patient that you would prefer to use a bispecific over a CAR, or would you always want a CAR if you had the availability?
If their disease let me do a CAR, I would want a CAR. And I will say, because I ask my patients, the ones that have a choice, I think that one and done is so big for relapse refractory patients that haven't had that break, and the quality of life piece is so important. But I think right now, the biggest issue is if I can't get that patient to that manufacturing slot, to the infusion, then we have to use something off the shelf to give them a shot.
Great, thank you very much, Dr. Patel. So now we're going to switch and talk a little bit about BCMA-targeted antibodies in relapse refractory multiple myeloma. So Karina talked to you about the 2 CAR T-cell therapies. I'm going to just say a few things about belantamab, and then we'll focus more on bispecific T-cell redirecting antibodies. There's also another option that's available for everybody, and that's selinexor and dexamethasone. We're not going to really talk about that in this session, but it's certainly an option, and we all use it sometimes either pre, post, bridging, et cetera. There's many places where you can use selinexor and dexamethasone. So the initial approval of belantamab mafodotin, a BCMA-targeted antibody drug conjugate, ADC, came from the DREAM-2 study. It was a phase 2 DREAM-2 study, and it was done in triple-class exposed patients, and the majority of the patients were refractory to CD38 antibodies. And the single agent at 2.5 milligrams per kilogram given IV every 3 weeks gave an overall response rate that was about 32%, and a duration of response was about 11 months. So it was a very active agent. So with that, a phase 3 for full approval by the FDA was developed, and that was initially the DREAM-3 study. And the DREAM-3 study data has now been released. This was a phase 3 study in relapse refractory multiple myeloma, similar patient population. 380 patients were involved, and patients were randomized 2-to-1 to belantamab mafodotin, a single agent, versus pomalidomide and dexamethasone. And the statistics of the trial was to show that belantamab was better than Pomdex. Unfortunately, when the data all came in, it turned out that it was pretty much a wash. The PFS was 11 months with belantamab, and it was 7 months with Pomdex, with a hazard ratio of 1.03, so no difference. So statistically, there was not an advantage, and it was not a superior result for belantamab mafodotin. And based on that, unfortunately, the FDA has taken belantamab off the market. I think we've all had patients that really have benefited belantamab mafodotin, and we hope it actually will be back on the market at some point. They still have 3 more shots on goal. We have the DREAM 7, 8, and 9 trials, some in relapse refractory myeloma in combination therapies, and then 1 in actually the newly diagnosed setting. So hopefully in the next year to 2 years, we'll have some data that perhaps will have this drug back in our toolkit. So let's talk a little bit about bispecific T-cell engagers. Now, the original bispecific therapy, it was a small molecule. It was 2 scFvs attached by a flexible linker. It was a very small, and it was traditionally from Amgen, a BiTE, called a BiTE, B-I-T-E molecule. And it, unfortunately, because it was such a small molecule, had a very short half-life, it needed to be given by continuous infusion. And we did have a BiTE from Amgen tested in myeloma, and in fact, it was the first one that showed very significant activity in relapse refractory disease. We all got very excited years ago. Since then, the therapeutics have really been changed to the right side of this slide, where they now have more of an antibody structure, where one FAB anchors itself to the myeloma cell, the other FAB binds to the, basically to the immune cell, typically a T cell, and binds to CD3. And there's an FC component that increases the half-life and allows us to give intermittent dosing. Now, there are more than 25 BCMA-targeted products currently under investigation. It's unbelievable. And they do differ. They differ by the way they bind to BCMA. Same thing with the CARs. Some bind with 2 binding domains, some bind with 1. They bind to different epitopes on BCMA. And they also differ by the way they activate CD3. Some are low activation binders, some are high activation binders. High activation binders may be associated with higher CRS. But the truth of the matter is as all the data unfolds, we see very little clinical differences between these differences in binding domains for BCMA and for CD3, with very high response rates in general in the whole class, and not as severe CRS. We'll talk more about that in a second. Now, the first BCMA bispecific that's been approved is teclistamab. And the benefit of this is now it's an off-the-shelf drug, right? We don't need to manufacture the CAR T cells. And teclistamab was basically approved based on the MajesTEC-1 study. The recommended phase 2 dosing of it was 1.5 milligrams per kilogram given by subcutaneous injection Q-week. And it was basically administered at full dose after 2 step-up doses. And so the way we do it in practice today is a patient comes in, they get dose number 1, 2 to 3 days later, they get step-up dose number 2, 2 to 3 days later, they get the first full dose, they're monitored for 48 hours, and then we can do all the dosing there after as an outpatient. We do hospitalize people at UCSF. Other centers are developing pathways to do this completely as an outpatient with other mechanisms for monitoring. But suffice it to say, this drug had significant activity. You'll see the overall response rate on the right. With 165 patients treated, the overall response rate in this relapse refractory, a very heavily pretreated population, 5 prior lines of therapy, of 63%. And 60% of the patients had VGPR or better, and in fact, 40% of the patients had complete responses. So high response rate, deep responses, and if we look at the duration of response, it was 18 months. And so durability also. This is new, right? This is new in this patient population for us to have such active agents. In addition, we're able to see patients achieve MRD negativity. If you look at the patients who achieved a CR or better, about half of them achieved an MRD negative status. We've never had drugs short of CAR T-cell therapy that could actually put a patient into MRD negativity in the truly refractory 3, 4, 5 prior lines of therapies. So these are really amazing drugs. PFS, 11 months. Overall survival at the current time, 18 months. Now, there are some practical points, and there is some some toxicity from bispecifics. The reason they're monitored for the step-up doses in the first full dose is because there is cytokine release syndrome, or CRS. It actually is 72%, so a little bit lower than with CAR T cells. It's almost all grade 1 and grade 2. And I tell my staff, CRS with these also always happens at 2 in the morning. So we get the calls, et cetera, but it's mini CRS with these. We really don't have to worry so much that they're going to go to the ICU. I don't think we've ever had, thankfully, knock on wood, a bispecific patient go to the ICU. It doesn't typically happen that they get very severe symptoms for their CRS. Usually lasts 1 to 2 days. We take the same strategy with bispecifics at UCSF, and this is where the art comes in too. With the first fever, we give them a dose of tocilizumab to take away the fever. We do it for a couple reasons. One, these are older patients. And actually the bispecific age, I think, are going to be, the average age is going to end up being older than CARs. And we don't want them having fevers for a couple days and then to have delirium and not be able to do the ice testing, et cetera. We want to turn off the fever right away. And there will be emerging data, and hopefully it'll be reported soon, that if you give them tocilizumab early on and with step-up dose 1, if they need it, they actually are less likely to have a subsequent CRS event with step-up dose 2 or the full dose number 1. So tocilizumab actually does work even in doses down the road that you're less likely to have recurrent CRS, which is kind of nice. On the right side of it, there is some neurotoxicity. It's again it's more mild than it is with CAR T cells. 14.5%. Most of it was headache. ICANS really a small percentage, 3%, and it's almost all grade 1 and 2. It typically occurs together with CRS. It occurs to the time when they have all these fevers. That's why I'm a big proponent of trying to turn that off as soon as possible. Now there's quite a few. I could have chosen 6 other agents to present today, but these are all showing very high activities in patients with relapsed refractory myeloma in the 3 or 4 or more prior lines of therapy. This is elranatamab, and this is the MagnetisM-1 study. All of these are dose escalation trials. And this one, they tested a priming dose before the full dose. They also tested a priming dose with pre-medications. And I think that the results are actually quite interesting. I'll show you more about that in a second. But in fact, if you take patients who received this bispecific and we look at those that received what we think is an effective dose, 215 micrograms per kilogram or more, you had an overall response rate 64%. It's almost always 60+% in these bispecifics. It's pretty amazing. With many patients achieving a VGPR or better, 60% or more, and in this one, 34% of the patients, 35% of the patients achieving a complete response. So very active, deep, and we'll see soon, hopefully, the durable remissions. Now, these are data just looking at, in the blue, the patients that had the priming dose, and in the orange, priming dose plus pre-medications. And this looks like cytokine levels in blood. And you could see a big difference. And so priming plus pre-medications actually works quite well. The pre-medications are what you would expect, acetaminophen, diphenhydramine, and dexamethasone. Now, here also it shows when you look at those in dose escalation that did not have priming versus those that just had priming, those that had priming plus pre-medications, the CRS incidence was the lowest, two-thirds, 66.7%, and those that got both priming and pre-medications. So what about moving these also, like you heard from Dr. Patel, moving these in earlier lines of therapy? So we heard data at ASH, and this was data looking at teclistamab in combination with daratumumab and lenalidomide in an earlier line of therapy. These are in patients that have had 1 to 3 prior lines of therapy, including a PI and an immunomodulatory drug. And so the patients still had step-up dosing, full dose, and then had daratumumab and lenalidomide added to their dosing. And you can see here, when you do earlier lines of therapy, the response rate's not 60%. The response rate now goes up to 93.5% in 1 to 3 prior lines of therapy. So how does that compare? I was an investigator on the Akima study, which was ESA, a CD38 plus carfilzomib index. And that is one of the studies in my mind that's had one of the highest overall response rates. in this 1 to 3 prior lines of therapy, we had an overall response rate right around 85%. So this is 93.5%. So seems like it compares favorably. We had about 40% CRs in the IKEMA. Here, the CRs are 55%, a little bit higher. It's very hard to do cross-trial comparisons, but I just say this because these are really good data. This is pretty amazing in these earlier lines of therapy. And what's going to really define this is the safety signals. Is it going to be safe to give these therapies in earlier lines of patients without getting any real toxicity from CRS, any real toxicity from ICANS, and any toxicity from infections? We'll talk more about infections in a minute. So there's also a Majestic-4 study that's planned. This is a basically post-induction, post-transplant, post-consolidation maintenance study. And the patients are going to be randomized at maintenance either to teclistamab and lenalidomide versus lenalidomide as standard therapy. And there's going to be a variety of assessments for MRD. And again, if we're going to start using these as maintenance post-frontline therapy, it's really, in my mind, going to be about safety. We already know with this strategy with lenalidomide, we get, based on determination, a 67-month PFS. Can we do better, and can we do it safely? So what we do know some reasons why patients don't respond so well to bispecific T-cell engagers. Having high-stage disease, having bulky disease, greater than 60% plasma cells in the bone marrow, and having extramedullary disease are signals that a single-agent bispecific may not be enough for these patients. I do think in some of those patients, CAR T-cells may be a better strategy at that point in time, but we also have to develop what combinations can these be used with to take care of these really high-risk patients that have EMD and have high-stage disease and high-risk cytogenetics. And that's something that we'll learn, I think, in the next few years. We're also noticing now that we're seeing more resistance due to loss of BCMA expression, and we're losing the antigen on the cell surface. It's on chromosome 16. We're seeing biallelic loss of chromosome 16. It's often associated with 17p deletions, so we're seeing that in some patients. Thankfully, we now have a CLIA certified test at UCSF where we can send their bone marrows to the flow lab, and they will flow them for BCMA expression before and after patients get a BCMA therapeutic. I think everybody who's going to be doing this needs to get assays like that going, because especially if we're going to go from one BCMA to the next, we really need to know, is the target on the cell surface. It's going to help when we are able to look at soluble BCMA levels. We still don't have a good assay for soluble BCMA, but if BCMA is on the cell surface, you're going to have soluble BCMA in the serum. Okay. Another thing that we are worried about and concerned about is in the teclistamab data, 75% of the patients are getting infections. And although the infections happen a lot in the first month or two, and that a lot of that is driven by neutropenia and it's CRS and our initial concerns of using growth factors in that early period of time, there are also infections that happen from month 2 to month 3 and month 3 to 6 and 6 to 12. And a lot of those are reactivation of a variety of viruses. And they also saw several cases of PJP. And so patients do need a prophylaxis regimen for infectious disease when they go on these therapies. Our typical is everybody's on acyclovir, everybody's on PJP prophylaxis. Everybody starts IVIG soon after them starting the bispecific. We just decided last week that patients are going to get IVIG starting on cycle 1, day 15, and they're going to continue that while they're on the bispecific. But there might be an advantage to do intermittent dosing of these therapies. If we just keep hitting the target, there's two things that potentially we could do. Is number one, we might develop resistance, obviously, in the tumor, but we also might develop more exhaustion in the T cells if we keep activating and keep activating. And so one of the things people are thinking is maybe we do need to do intermittent exposure of these drugs so that we can have less exhaustion of the T cells. So these are concepts that hopefully we'll have more data to present in the next few years. Okay, just like Karina showed you, there's a few sequencing things. There's some retrospective reviews, one from Mount Sinai, looking at can you go from TCE to TCE? Can you go from CAR to TCE? And the answer, in fact, is yes. And you do see activation of T cells. The orange curve are patients who've went from one BCMA to the next, or one TCE to the next, showing that that strategy is actually better than the black curve when you go from a BCMA-targeted therapy back to the other stuff that we have, a mix of CD38s, IMiDs, bispecifics, IMiDs, PIs, in alkylators. That doesn't work so well, you can tell in the black curves. There was a Majestic-1 had a cohort C looking at teclistamab, and the bar graphs on the upper left, you see with the ADC, the exposed patients still had a really good response rate of 55%. CAR T exposed, 53%. ADC or CAR T overall was 52.5%. And on the right, the swim lane plot, some people are actually having fairly durable responses. Same thing with magnetism. They allowed some patients with prior BCMA. It's pointed in the arrow on the upper left, but in fact, it was only 13 patients, but 7 out of 13, or half the patients, were able to respond and actually have some durability based on the swimmer's plot. Now, we do have some other targets, right? So the nice thing is that the BCMA is a pillar in my mind, but these pillars are going to be much bigger because we're going to have other targets that we can go after. One is GPRC5D, and the bispecific antibody telketamab, which binds to GPRC5D on the plasma cell and also activates through CD3, is another very active bispecific. This is data that was presented by Ajay Chari at ASH, showing that in heavily pretreated patient populations, the overall response rate from telketamab, either given at a weekly dosing of 400 micrograms per kilogram weekly or 800 every other week, is 73 and 74%. Pretty amazing, actually. And we also have another one targeting FcRH5. And this is a drug called cevostamab from Genentech. In the bottom right, showing very high response rates, 58%, 55%. So pretty amazing overall response rates. So this is, these are drugs now that we have in our armamentarium. We have drugs that we can actually treat patients today. I think in a minute, we're going to open up to questions for everybody, so think about your questions. In terms of some of the concepts of patient selection and treatment selection with bispecifics, Karina already alluded to this. Patients that are progressing fast and cannot actually wait for their slot to get harvested, lymphocytes harvested for CAR T, you actually, I think, have to put those people on bispecifics right away. We have to control their myeloma. That's obviously the most important thing. Age is not a factor at all in my mind of bispecifics. I was on a call last week with a lot of people, and I told them I have a 98-year-old in, I have an 88-year-old, and they were asking me, isn't that too old for bispecific? Absolutely not. As long as they're fit and they're actually doing okay, these are drugs that you can use in the older population. And so age in bispecifics, in my mind, is not an issue whatsoever. The fitness, I do try to send more of my fit patients to CAR if they can get them, but in the less fit patients, I think can go on to bispecifics. In terms of infection management, I told you a little bit about our protocol, but we still don't know, and we're going to have some guidelines come out soon for infectious management of bispecifics. There's going to be a couple guidelines papers. And we're seeing CMV reactivation, we're seeing parvovirus reactivation, we're seeing activation of viruses that our other drugs, we really didn't see much of that. So we just have to be aware of it. The question really is going to be, how do we have to treat them? Is IVIG enough to treat them? And what else do we have to incorporate into our infectious disease algorithm? It's going to be really important for us to define those. And then, what else can we combine the bispecifics with? Certainly IMiDs. You're already hearing data from lenalidomide. There's data with pomalidomide. There's also going to be data with CELMoDs, hopefully coming down the road. Everybody's interested in combining CELMoDs with these because CELMoDs have the most immune stimulation. And then hopefully doing treatment-defined periods of therapy where they get maybe the bispecific for 12 months and then they're off. Maybe they'll continue the CELMoD or the IMiD for another year, and if their MRD is sustained, maybe we can give them a break from therapy. Just like CAR T-cell, that would really be the holy grail in my mind for bispecifics. All right, very good. And with that, we'll open up the floor to questions. If anybody has a question, you can come to the mic. We also have a bunch of cards that we'll read off. Can you turn the microphones off at the table here? I mean, on at the table?
Hello? Yep.
Perfect. All right, so we have some questions. I'll start with the easy ones, Karina. So age in CAR T, any issue with age in CAR T?
For the most part, no. I think, again, performance status and can they get through and do fludarabine and lymphodepletion, then no age limit.
Ooh, we have a couple transplant questions. One, is CAR T take away the need to do a tandem transplant? And then the role of second auto transplants in the modern era. Is there any role for second auto transplant?
You want me to answer that? Okay. So
you're from MD Anderson, yes.
Having been a transplanter.
Do more transplants than anybody.
So I think for us, most of our patients, there was only about 10% of patients we were doing a second auto for as we got some of these novel therapies. And now with even more novel therapies with BCMA, most of our patients, we use a second auto if their counts are really low or post-CAR T, but they're in good shape and we want to wait till the next big thing comes through. That's sort of where we use it. We don't use much tandem transplant at MD Anderson either. So I think for now, I don't think CAR T replaces transplant yet, but hopefully trials like CARTITUDE-6 that are looking at that in the future will help us decide.
At the microphone.
Hello, Laurent Garderet from Paris. Do you have any experience with T-cell engagers and renal insufficiency, like less than 30 milliliter per minute of creatinine clearance?
I can say I have 3 patients right now, 2 on dialysis, 1 with the grade, probably GFR of like 10 getting it, and their first week has been fantastic. I will tell you long term, I will say that a couple of those patients had more neutropenia already with other therapies, so the prophylaxis we're giving them is much more, and our ID colleagues are fantastic, so we're thinking about possibly fungal infections because of their HD catheter, so we're doing a lot of extra prophylaxis for them, but I'll let you know, maybe a couple months from now.
So I'll answer that too, because I do also have a dialysis patient that's doing really well, and that's one of the reasons that I do target people to a bispecific is where their creatinine clearance is. If it's less than 30, then I say let's just go with the bispecific, and it's been successful actually in that regard, yes, without much tumor lysis.
Thank you. Just one comment. Of course, we are all very excited with the combinations with IMiDs or whatever, CELMoDs, and also with daratumumab, but there was a signal last week, if I'm correct, with a fixed dose of teclistamab plus daratumumab with an increased death. I'm sure you're aware of that.
Right. Yeah, so to use them together, the CD38 antibody might actually take care of some of the CD38 positive Tregs in the bone marrow, so some of the immunosuppressive microenvironment. So daratumumab, not used as trying to target the myeloma cell, but actually to target the CD38 expressing T cells in the marrow and B cells in the marrow, the immunosuppressive microenvironment. And so I do think that there's a possibility. I will say that what's the important component of that, which we really need to know more data about, is does that change the infectious profile? And so I am a little nervous about the two together for a long period of time because of the infectious disease profile. And I think we're going to have data over time that suggests that maybe we don't do that for so long. All right, so I got a question from Jack Aiello. And I have to always answer Jack Aiello's questions. I don't know if anybody knows Jack, but he is the leader of the Bay Area Myeloma Support Group, and he's taken so many patients through myeloma. He's at every meeting I'm at, and he's the most knowledgeable person I know in multiple myeloma. His question is, since UCSF uses TOSI at the first signs of CRS, what do you think about using TOSI prophylactically seen in Cevostamab trial? That's a great question, Jack, as usual. And I asked on this call I was on last week if anybody started to use TOSI as prophylaxis. Nobody said yes yet, but I do think that that's something that's going to be tested, because yes, I think it's a good, if we can prevent people from needing to go into the hospital because they have very little risk of CRS, I think it's worthwhile testing. Have you done it all?
So I'm having trouble getting TOC approved as outpatient for standard of care. So I think we'll need trials like cevostamab to show that it works so that then I can actually do it. But yeah, I think there's a potential.
All right, so a couple for you. Was the PFS in KarMMa-3 expected to be better than 13.4 months since the study was earlier lines of therapy? Good question.
That's a great question. So before any of the studies, I would say yes. I was hoping for a cure for BCMA bispecifics or CAR T moving them up earlier would hopefully cure some of our patients, and we're not seeing that. But if you look at that, the control arm, these patients are overall very resistant in general. Now, these patients had DARA, so using these different options, we don't have clear historical data to say what do we expect for these patients. I will say the patients I've put on this trial, which were multiple patients that had ultra high risk, because that was the most novel thing I had, they've done really well compared to what I know they would have done. So I think we need more subset analyses to see what the signal really is. But compared to what we have available, I do think it was a phenomenal result. I sort of estimated that this was what it would be.
All right, so bridging therapy, what do you use? And then what about bendamustine for LD therapy?
Yeah, so I think bendamustine has been used in a couple of different centers when we were low on fludarabine on and off. So we'll have some of that data in the near future on responses and results versus other regimens we've done. I think especially for certain patient populations, it might be better, but I think we just need more data. Everything's been done with FC. Bridging, that's really important. Again, there have been patients where we know that if your myeloma is controlled or at least going down on the way to CAR T, you're going to do much better in terms of response, in terms of toxicity, et cetera. But you don't want to overdo it with bridging where patients end up with worse infections because now we've given them, cytopenias even before they went into CAR T. And that's happened with a couple of my patients where they got worse infections after because of that. So we're trying to find that medium. We use whatever we can to, again, make sure they don't get toxicity with infections mostly right before CAR T, but making sure their myeloma stays controlled going in.
And then another one, just in terms of using non-BCMA targeted activating agents as a bridge. What do you think about that?
I can't wait.
Yeah.
The day
It's a great question, and yes, we all want to do that, actually. We want to collect their cells, give them whatever, talquetamab, cevostamab, for a month or 2 months while we're waiting for the cells to be manufactured, and then give them the CAR, hopefully with minimal residual disease, and they'll have a longer PFS. That would be awesome. Okay, another one, I just have 2 more, and then we're all set. You guys have asked great questions. Do BCMA-targeted CAR antibodies bind to different epitopes at the BCMA molecule, and can they be synergistic? So the CARs and the BiTEs, do they bind to a different epitope, and can you use them together?
Yeah, that's a great question. I don't know all the specific ones for all the 35 different kinds that are being evaluated right now, but there are different epitopes. For instance, Silta has 2. And so I do think that there could be a way to help improve. And some of the data from Canada, Nazar, Baylis, where we are seeing some patients with point mutations, et cetera, in different epitopes of BCMA would help us with resistance maybe.
And then long-term neurotoxicity? With cilta-cel, anything to say?
Yeah, sorry, I didn't mention that. So I know on the trial it was 9%, that initially had this delayed neurotoxicity. I have not seen it yet in our patients. Hopefully we'll have some more real-world data to talk about that. It is something that we have our neuro team monitoring our patients up to day 100 in case we have any symptoms that resemble that, and we try to intervene quickly. But again, I haven't had to deal with that in the real-world population, which I was a little bit afraid of before.
And then the last question, it's about infections. And somebody asked, because I said cycle 1, day 15, we use IVIG. Does insurance give us pushback? And what about if they have a high level of immunoglobulin at that point in time? So yes, I don't want to say that we're going rogue at UCSF, but that said, most of the patients already actually have hypogammaglobulinemia at that point in time, often from their prior therapy. But if they had an IgG that was 4,000 or so, we wouldn't potentially give it on cycle 1, day 15 if their IgG was still high. As you guys know, the metabolism of immunoglobulin is based on the level. So if the level's real high, the body metabolizes it faster. So if you give IVIG with a high level, then you're just going to chew it up really fast. Basically, it doesn't really work. So that's why the M protein goes down really slow over time, is because you metabolize less when it's low. That's why you get more bang for your buck if you wait till it gets lower. But very important to watch closely for signs of infection. Any fevers, signs of infection, you do have to do what I'd say is an exhaustive workup in my mind. This isn't just, okay, you give them a Z-Pack and tell them, okay, we'll see you next week. We actually do CMV, PCRs, we do adenoviral PCRs, we do basically parvoviral PCRs, et cetera. And so the take-home message from me for this is these are a new therapy that we're just learning on all the infectious diseases that can occur with them, and just be very careful when you're doing that. Last thoughts from you, Karina?
Yeah, no, I think it's really exciting, but the infectious piece in these relapse refractory patients is so, so important. So even if you think it's CRS, just make sure it's not an infection too.
And with that, thank you so much for coming to our session. Thanks for all the questions.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FNM860. This activity is supported through educational grants from Bristol Myers Squibb and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. This activity is certified by the Medical College of Wisconsin. This activity is co-provided with our educational partner, PVI, Peerview Institute for Medical Education. Remember to download the slides and practice aids.